So today we're going to go over muscle energy and HVLA treatment for the cervical spine, including the occipital-atlantal joint, the atlantoaxial joint, and the typical cervical spine. We're going to start with the OA joint and start with muscle energy. Once you've established a diagnosis, you want to place the patient into their barrier in all planes. So if, for example, he was extended, side bend right, rotated left as his diagnosis, we would want to flex him, side bend him left, and rotate him right into that position. And then to engage, we're going to have him lift his chin up towards the ceiling. And then relax. As he relaxes, we're going to take him further into flexion. Lift your head up towards the ceiling. And relax. As he relaxes, we're going to take him further. One more time, lift up. And relax. As he relaxes, we would take him even further into that barrier. And then we would do our reassessment. If he had, for example, a flexion dysfunction, if he was flexed, side bend left, rotated right, then to treat, we would extend, side bend right, rotate left, and we would have him pull his chin down into our hand this way to engage. And then relax. After he relaxes, we would push him further into extension into that barrier. And we would repeat that for 3 to 5 cycles, 3 to 5 seconds apiece. If we were going to do HVLA for the OA joint, we would do essentially the same setup, except that we would want our MCP down onto the occiput, so behind the mastoid process, onto the occiput here. And when we take the patient into that barrier, then we would be able to apply thrust. And the thrust in the OA joint can either be a translational thrust, in other words, thrusting into side bending, or it can be a slight rotational thrust, thrusting into rotation. Generally, people prefer to do side bending as their thrust, but either is acceptable in the OA. The main issue is just having your MCP up on the occiput as opposed to down in the cervical spine. In the case of the AA would be either rotated left or rotated right. The contact point is the transverse process of the AA, which is just between the mandible and the mastoid process. And you would have made this diagnosis with the patient's head flexed up, but when it comes time to treatment, we're going to treat with the head in neutral. And we're going to simply grab a hold of the head and turn the head as far as it can go in one direction. So if he was AA rotated left, we would treat him by bringing him to the right, which would be his barrier. And then from here we would have him turn his head to the left as we resisted and relax. And we would repeat that 3 to 5 cycles. Similarly, if we were going to do HVLA for the AA joint, we would want to apply slight traction on the head. We would want to take him all the way into his barrier in rotation, and then the treatment would be a pure rotational thrust with a slight bit of traction just to isolate up to the AA joint. In the case of the typical cervicals, so C2 through C7, if you were going to treat with muscle energy, you would take the cervical segment and put it into its barrier in all planes. So if you had C3, which was flexed, rotated right, side bent right, you would contact that one segment at C3. You would tilt the cervical spine into extension. You would side bend left and rotate left. And then you would have the patient turn their head to neutral position as you resisted. And you would treat, relax, and you would treat that again 3 to 5 cycles, 3 to 5 seconds apiece. If you wanted to do typical cervical HVLA, there's 2 methods to do this. One is a rotational focus thrust. In the case of that same diagnosis, C3, flexed, rotated right, side bent right. If you were going to do a rotational thrust, you would take your MCP and contact the articular pillar of C3. You would push in to translate that segment to the left, which is going to produce side bending into the E's. And then you would rotate the segment to the left, which is rotating into the barrier. You'd have the patient do respiratory cycles and breathe out, and your thrust would be a rotational thrust to correct that segment. For that same dysfunction, if we were going to do a side bending emphasis, for C3, flexed, rotated right, side bend right, we would contact the MCP on the opposite side at the level of C3. And this time we would translate into the barrier. So by translating him to the right, we are side bending him left, which is into his barrier. We would rotate him to the right into his ease, and then our thrust is going to be a side bending thrust, bringing this MCP towards the opposite shoulder and bringing the head slightly towards the same shoulder. So from here, the thrust would be like this, side bending thrust. Generally speaking, you want to use the rotational focus for upper cervicals, and you want to use the side bending focus for lower cervicals, although you can use either technique for either. It just comes down to which version the segment will respond to. So that is how we are going to do cervical spine, muscle energy, and HVLA.